Hi, this is Brian Kim. I'm going to share with you this case of a patient who came to see me for a second opinion. She was frustrated that her doctor would not perform her cataract surgery even though she was vocalizing significant visual trouble. She also has glaucoma and iris atrophy and a shallow chamber, and so I suspect the surgeon was reluctant to do it because of this complex situation. And so she sought my care, and we went ahead and planned to do cataract surgery, and you'll see kind of how I handle this case. And so you can see here, I'm holding the eye with a cotton tip, and you can see I'm pausing here, just showing my staff the significant diffuse iris atrophy she has. She also has a little bit of a shallow chamber, but it's a really nice sized pupil, and so I'm not really anticipating any significant trouble as long as the shallowing doesn't cause any trouble, and as long as this iris atrophy doesn't cause any significant IFIS. And so I've marked the central cornea for my corneal mark, which will help me to center and size my rhexis. I'm using the cotton tip to turn the eye, turning it towards the left, and making a stab incision on the right side, flat to the iris plane. You can see this is the right eye. I'm using cotton tip to turn the eye towards the right, and then making a stab incision on the left side, again, parallel to the iris plane to get a nice corneal shelf, which will allow me to help get a self-sealing corneal incision. I'm injecting some intracameral lidocaine, and then I did inject some intracameral epinephrine. I'm injecting some dispersive viscoelastic to fill the anterior chamber, coat the corneal endothelium, and flatten the anterior capsule. Make my triplanar corneal incision and make a vertical groove. Place the blade into the deep part of the groove, tunnel through the cornea, turn the eye towards me using the cannula, and then enter. That's a triplanar corneal incision. And so now I'm going to do the puncture-style Capsulorhexis. I'm turning the teeth to the side, sliding in, straightening it out. I'm going to puncture centrally. You can see the rhexis is not trying to come the way I want to. You can see there's a little bit of a capsular stria there. It does make me wonder if there's some zonulopathy, but I go ahead and follow the capsule the way it wanted me to go. And I'm going around circumferentially, grabbing and re-grabbing. When I have encountered that situation where the capsule doesn't want to go where I want to, I do suspect there might be some zonular problems. And again, this goes with the patient having this atrophic iris. So I finished the rhexis, burp a little bit viscoelastic. This is the capsular fornix hydrodissection technique. Place the cannula out underneath the anterior capsule to the contralateral equator. Point the tip down, get a nice wave, decompress on the left side, and you can see the lens is starting to spin quite easily on the right side. I lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. I remove the surface epinuclear material. I'm going to place the chopper underneath the epinuclear ridge out to the equator. Place the phaco tip vertically sub-incisionally, bring both instruments together, crushing and dividing the lens. This is the double chop maneuver. Place the chopper out to the contralateral equator, pulling it central toward the phaco tip. This crushes and bisects the right heminucleus. That's the cross chop maneuver. I use vacuum to pull that first quadrant up and emulsify the lens piece. And then I use the chopper to pull the second quadrant up and then emulsify the lens piece. Use a chopper to turn the second heminucleus in front of me, place the chopper around the equator, pulling it centrally towards the phaco tip, dividing the third and fourth quadrants, using vacuum to remove and pull up that third quadrant and emulsify, and then doing the same thing with the fourth quadrant. Starting to remove the epinuclear material, and this is going, again, fairly routinely. So far, I am not encountering any trouble. I'm not seeing any particular reasons to get really excited or nervous about her case. There's no significant posterior pressure, shallowing, or anything like that. So I take the chopper out, push BSS in, take the phaco tip out, switch it with the INA handpiece. I'm starting sub-incisionally, removing the sub-incisional cortical material, get a nice occlusion, grabbing the cortex on the anterior side, sweeping a little bit side to side, loosening it, get occlusion, and then pulling it with mechanical forces, peeling it off. So I'm going around circumferentially, again, making sure I grab the anterior portion of the cortical material, using high vacuum, and it comes out of the bag pretty easily here. Switch to the polish mode. I'm going to polish underneath the anterior capsulorhexis edge. Again, this patient had some suggestion of a little bit of a weak zonule. Also, the iris is atrophic. So you don't really want to use high vacuum into the capsular fornix. You might grab the bag and stretch the zonules. It's just not worth it. So I can see that the bag is pretty clean. I'm starting to polish the posterior capsule surface as well. Again, I'm confident, but you don't want to use really aggressive movements. You just want to tease the remnants off. There's no reason to make a big windshield wiper movements with the posterior capsule polishing. So going to the cannula, pushing BSS into the subincisional capsular fornix. It's nice and clean. And then I'm injecting some cohesive viscoelastic to inflate the capsular bag. And simultaneously, I'm placing a sweep on the other side. I'm going to polish the left side first, underneath the anterior capsulorhexis edge, removing the lens epithelial cells. And doing the same thing on the right side now. So far, no major disasters, no major real considerations as far as any potential difficulties or challenges. I'm injecting the single piece acrylic intraocular lens into the capsular bag. I'm going to go in, turning on the irrigation once I'm in, disengaging the leading haptic and trailing haptic, getting underneath the optic, rotating it and tilting it 90 degrees, making sure both haptics are in the bag, and removing all the viscoelastic from within the bag. So far everything looks really good. But then I see something, I feel like maybe there's some material stuck underneath the lens. It's right there, you can see I'm polishing it. You might not be able to see it because on the cornea there's a little bit of an irregularity on the cornea, so it's right in that same area. There's something weird about the lens. And so I went underneath the lens, tried to remove that opacity there, and then I tried to get on the surface of the lens. Didn't work. So I'm deciding to turn the lens. I kind of rotated the lens a little bit towards me more, so that opacity is now on the right side of the lens, on the edge. I get under it. I'm really using high vacuum to see if I can remove that material. I ask her to clear the corneal surface to get rid of that artifact on the cornea. So I switched to visco mode, trying to use really high vacuum to see if I can remove whatever's stuck to the lens, hoping that it's stuck to the lens on the underside as well as on top of the lens. You see now I'm actually using the INA to kind of turn the lens and make it glisten against the microscope light. When I have it glisten against the light, I can tell this is not just material stuck on the lens. There's actually a defect in the lens. So now I have a tough decision to make. It's not in the central part of the optic, but it is on the optic nonetheless. So I make the tough decision to go ahead and exchange the lens. I place the cohesive viscoelastic cannula through the paracentesis. As I had the optic tilted up, I fill the bag completely with cohesive viscoelastic. Very carefully with the teeth closed, I manipulate the optic, grab it with the forceps on the left side, and very carefully cutting the lens with the scissors on the right side. You can see I'm turning the teeth more parallel to the optic. It's not up and down, it's more sideways. This helps give me a better visual of the teeth, and it also keeps the teeth away from the posterior capsule. I'm still holding the optic with the forceps on the left side. I release it now by holding it with the right side, and I'm using the left forceps to manipulate the haptic so I can grasp it. and then I let go on both sides, grasping the haptic with the right hand, protecting the cornea with the left hand forceps as a guard. Once the haptic is externalized, I re-grab with the right hand forceps, and then I pull the lens out. So this second half is still in the bag. I'm just pushing the optic so that I can get underneath the edge there. Push it some more, and now I'm able to get under it. Open the teeth, grasp the lens material at the level of the optic. The haptic is away from me, and I'm able to pull it out quite nicely. I'm filling the bag again with some cohesive viscoelastic, and I'm starting all over. I'm injecting the single piece acrylic intraocular lens into the capsular bag, hoping that the optic of this lens will be fine. Go in and then start irrigation, disengage the leading and trailing haptics, getting under the optic, tilting it, rotating it 90 degrees, removing all the viscoelastic from within the bag. Polishing, I'm rotating the haptics in the horizontal position, and then I'm removing all the viscoelastic and pretty much finishing up the case. So again, this patient came in for a second opinion. I was anticipating this was going to be a complicated case with iris atrophy, shallow chamber, but really all of that ended up being quite uneventful. And actually the most unexpected part of this was the IOL exchange. But you could see by very careful technique, I'm able to cut the lens out very carefully using viscoelastic and using these micro instruments. I've never been a fan of putting two lenses in the eye, putting the second lens in the bag, and then cutting the other lens. I feel like that could be helpful, but there are potential risks, especially you don't want to damage the cornea. But I do feel that if you have good technique, cutting the lens the way I did, I do feel like this approach is very controlled and can make it fairly routine. So I hope this was helpful to you, and I thank you for your attention.